We introduce now this session with round table predictors of cochlear implant outcome. Our moderator, Dr. Alaa Abou Setta. I am sure that we will listen to very nice presentation.
I hope so.
Because we are very late, start directly, Dr. Alaa. And
Inshallah.
As much as we can,
We go quickly.
the time.
Thank you, Professor Adel. Good afternoon, everybody. I hope that we will have a nice session with all the distinguished guests, Professor Naema Ismail, Professor Ossama Sobhi, Professor Takwa, Gabr, and myself with you, talking about, it's a round table discussion, talking about a very important issue, which is predictors of cochlear implant outcome. As we all know, we always want to know how are we going to counsel the patient, what is our expectations about cochlear implant outcome. There are always in our practice important questions, which is how good is this candidate for cochlear implant? And then after we do the implantation, who achieved a successful cochlear implant? And which cochlear implant program in a certain institution is better than the other, is performing better than the other? And for the same institution, we can ask ourselves, are we improving or not? There is a concept that I want to emphasize before we start the roundtable discussion, which is the concept of the added value. Our efforts in the rehabilitation of a hearing impaired child or a person who is candidate for cochlear implant, all our efforts, including the surgical, the audiological, the phoniatric efforts, will put an added value. If we can imagine that we have 4 categories of patients, and then we have the preoperative, if we can imagine that we score the preoperative condition with this light green, and the postoperative performance with the blue line. So if we look at the category 1 patient and category 2 patient, we cannot, if we look to the postoperative performance, it would be unfair to look to both patients equally without looking to their preoperative condition. Of course, in category 2, there is a huge effort done to reach the same level in comparison to category 1 patient, which had more favorable preoperative conditions. And when we look to the category 3 patient, of course, when we look to him from the outcome, the final outcome, he would appear, or the patient would appear less performing than category, for example, 2. But if we compare our added value, it would be the same. It's the same effort done because his preoperative condition in category 3 was less favorable than category 2, for example. So we cannot blame the team, we cannot blame the cochlear implant team. And also, moreover, in category 4 patient, which had a very, very favorable preoperative condition, but they reached the same performance like category 3, we can easily blame ourselves and revise our protocols and our efforts to see where is the defect. So this concept I wanted to emphasize before we go further. So in order to improve our performance, the advantages of having a cochlear implant performance predictors is, first, it helps in decision making to do the operation or not, adjustment of expectations, and of course in the counseling of the patient or the family. It helps in putting prioritization in selection, especially when you have financing implant problems or restrictions in the financing the implants, like the insurance system here in Egypt or in the third world. And third, the implantation team could understand the performance relative to the expectations and hence adjust the rehabilitative efforts. Fourth, it helps each team to monitor its performance, as we said. And lastly, this can give us insight into the added value of the cochlear implant team. And so we thank you. I would like to thank you in the first presentation. This was just an introduction, an intro to this round table, and then we can go further by inviting Professor Naema Ismail to give us her first presentation. and then we continue the discussion. Thank you.
Thank you very much, Mr. Chairman. Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing and scientific committee for giving us the chance to share in this scientific event. Actually, we are going to present the outcomes of different genotypes in patients with neuropathy in a systematic review manner. This is a new way of looking at our research. Our learning objectives of this research include, first, to explain the need for a systematic review. Why do we need to do it? Second, to understand the pathophysiological mechanisms underlying the genetically based neuropathy. Third, to explore the predictor of CI outcomes in this neuropathy. And finally, to highlight on our research conducted at Al-Zahra University Hospital. Why do we need to do a systematic review in our research? We know that as evidence-based practice, we have a pyramid of research. The top part of it stands for the systematic review. Why? Because we have filtered information, and the other bottom part contain unfiltered information. So the publication of systematic review for any topic can enhance time needed for this task by retrieving research that brings together collection of highest medical quality publication and give more evidence about a specific research question. So we are answering a specific research question here. In response, there has been a need for development and application of standardized groups of fundamental outcomes and minimum reporting requirements for CI studies, termed what we call the core outcome sets. Such core outcome sets would certainly enable enhanced appraisal, mean criticizing of efficiency and arrangement of data across the studies. These are the stages of the systematic review. When we do systematic, we have to go through all 10 steps, starting by scoping of the research, finally report writing. We need to understand some physiological background here. We know that the components of peripheral auditory system concerning CI physiology divided into 3 conceptual parts we see here. We have the sensory, synaptic, and neural. And we know that the sensory is responsible for mechanoelectrical transduction of waves into electrical signals through the action of the hair cells of organ of Corti. The synapse includes presynaptic site. And finally, the neural partition, which is at the bottom here. Distal neurite of spiral ganglion, and it is very important because it adds to the dorsal cochlear nucleus here. We know that the CI bypasses the sensory and synaptic. Here, this part and this part bypassed by the CI. So this part, the neural part, is required for optimal CI benefit. We know that the auditory neuropathy is a disorder. We all know that it is not related to intensity, it is related to time. So this is the problem. This is the difference between it and the difference between neuropathy and other sensory neural hearing loss. So these perceptual consequences are the opposite of what is typically seen in other cochlear impaired subjects, because there is an inability to effectively transmit neural signal to the brain. Increasing the sound stimulus in this case through hearing aids or CI or any whatever may have limited benefits for this patient. We know that the 3 divisions, anatomical divisions in the neuropathy include presynaptic, postsynaptic, and central neuropathy. We have 3 types of neuropathy. So we can see different variable results because the lesion is not the same in every patient. In the presynaptic auditory neuropathy, such as the otopharyngeal mutation, the site of lesion is the inner hair cells or ribbon synapse. The underlying pathophysiology is a combination of reduction in volume of glutamate and increased latency period in its release at ribbon synapses, resulting in disruption of temporal coding. So this results in temporal lesion. The specific genetic lesions that cause presynaptic lesions, the most famous one is the OTOF and GAGB2. Okay, the mutation in Operative gene were the first recognized genetic condition to cause the neuropathy. Operative acts as a calcium sensor at presynaptic site of inner hair cells. Some mutations of Operative are responsible for type of hearing loss sensitive to temperature because they call it temperature sensitive genes. Sometimes we see the child when he had some fever, he has hearing loss. The hearing is affected. Why? Because he has what we call the temperature sensitive genes. GGB2 gene encodes gap junction protein connexin 26 that is involved in common in most autosomal recessive non-syndromic hearing loss. In postsynaptic, we have specific lesion postsynaptic like this. These are the postsynaptic. This is optic atrophy. This is the one gene for optic atrophy syndrome. Temperance gene, which occurs in Charcot-Marie-Tooth syndrome. In postsynaptic auditory neuropathy, dysfunction can occur at multiple sites along the auditory nerve pathway, including unmyelinated auditory nerve, dendrite or auditory ganglion, and their myelinated axon and dendrites. Okay, for predictors of CI outcome in neuropathy, some of the strongest predictors are clinical factors associated with hearing loss. Outcomes are poor in patients with absent cochlear nerve, of course, or severely narrowed internal auditory canal. The cochlear nerve size, okay, also is essential. Hypoplasia of internal auditory canal. Cochlear implant outcomes in patients with presynaptic localization are good and better than those with postsynaptic, which give unsatisfactory results. Now we will highlight quickly on our research. We have seen from the literature that there have been unresolved controversies in the literature surrounding interventions and recommendations and giving variability of CI outcomes in neuropathy patients, particularly with confirmed genetic etiologies. So there is a growing need to assess the implications of identified genetic phenotypic association. That's why we started to look and dig into evidence-based practice and did our systematic review. We had 3 aims in our study. First, to capture additional data, including papers starting from 2005, to understand correlation between different genotypes and CI outcome, and to sensitize and analyze the existing data regarding the different genotypes on CI outcome to help in decision making in CI and to determine good and poor outcome of CI associated with different genes in patients with neuropathy, whether syndromic or non-syndromic. We had one research question following what we call the PICO research. Can cochlear implantation outcome be predicted from genetic variants in patients with neuropathy? That's why we did this was our aim, and this was our research question. We did, and we followed the meta-analysis protocol, PRISMA 2020 protocol, and we registered it on Prospero site. We had some inclusion criteria like the cohort. We included cohort studies, systematic reviews, adults with CI genetic testing, post-implantation outcome, and excluded other studies, like case reports or narratives or whatever. This is our flow chart. We started here in the study by 547 citations, and after removal and filtering, we finally ended up with 20 studies to be included in our systematic review. All these are just details we have to skip for time. We had some limitations because some studies had small sample size, and this was one of our studies, and some studies had rare genes, and we didn't find a lot of literature on them. And we started to look on the MBase, which was not available all the time. Finally, to sum up our findings, cochlear implantation in patients with neuropathy requires special consideration because the outcome is more unpredictable than in patients with cochlear sensory hearing loss. By demonstrating satisfactory CI outcomes in neuropathy patients with some genetic mutations, such as the Operative and GGBT, which is very important, and ATP and OP, optic atrophy mutations, the outcome of some genetic variants showed controversy, such as the Tempress gene, who showed better results with prolonged hearing aid use or electroacoustic use, did not give any good response with CI. Neuropathy subjects segregating out of mutation consistently receive benefit from CI. This study confirms the utility of genetic diagnosis to identify a specific subcategory of appropriate CI candidate among neuropathy patients. Subjects with identifiable genetic mutations could benefit from early CI to a greater extent than those with unidentifiable genetic etiology, which provides a reasoning for early CI. Genetic testing may provide an ideal window period in terms of CI timing, because the timing is very important for satisfactory outcome according to genetic etiology. Some centers abroad do the genetic testing routinely now, but as it is very expensive here, we cannot afford to do it routinely. So further recommendations are needed. First, an important clinical implication is that genetic examination should be included in the pre-CI evaluation battery in neuropathy to improve the outcome prediction capabilities. The neonatal hearing screening, which we use already using only mission early diagnosis of neuropathy patients, could be lost because we depend only on one tool. This could postpone their diagnosis until preschool or school age. Late diagnosis will deprive those patients from early rehabilitation. It could be better to use automated ABR, if possible, for neonatal screening. Some of these patients with delayed diagnosis, many of them will have severe hearing impairment, and delayed diagnosis can lead to some optimal outcomes. And thank you very much for your attention.
Now we invite Professor Takwa.
Good afternoon, dear professors and colleagues. Now I am going to talk about preoperative and operative predictor for CI better outcome. As we know that outcomes of cochlear implant show great variability, and many factors are contributing to this outcome. Some children achieve language acquisition within the normal range, while many cases are delayed. First, we should answer this question: what is considered a good outcome for cochlear implant? We can answer this by finding the case that has the ability to understand speech at nearly normal level without lip reading, are capable of do telephone conversation and watching TV, improved listening to music, improved perception of a variety of sound, and better modulations of one's own voice. The preoperative factors are divided into two main categories. First, related to the candidacy of CI, and second, the category related to the selection of the device. Regarding the candidacy, we have many factors, such as first, the age of onset of hearing loss. We know that. Second, we have the age of implantation, and many research showed that the better age of implantation between the age of 2 and 5 years, and now we see a lot of cases implanted at the age of 1 year. Regarding the duration of the hearing loss, the shorter duration, the better, in order to avoid retrograde neural degeneration, the adverse effect on the connection between and among neurons in central auditory pathway, and to avoid, of course, the cross-modal plasticity. Regarding the residual hearing, it is very important now to preserve hearing, because many patients have low frequency residual hearing, and if the patient is able to utilize this low frequency sound, there will be a better listening experience. Another important cause is to ensure that the neural structure in the cochlea are left undamaged, enabling the patient to benefit from future therapy and technologies. And of course, if the patient has adequate low frequency hearing threshold, he should be fitted with electroacoustic stimulation. Regarding the cause of hearing loss, we have cases with congenital anomalies that carry a risk of incomplete insertion, gusher or facial nerve apparency that appear either intra or post-operative. We have also improvement in the cases after long-term follow-up. Cases with implantation who has Mondini dysplasia or cochlear nerve deficiency showed good results, and we have many cases of auditory neuropathy that showed good results, especially in the presynaptic cases. The preoperative use of hearing aids for at least 3 months is very important because it helps to avoid the accelerated central and the peripheral modification as a result of auditory deprivation, and also slow down the pathological reorganization of the auditory pathway and makes the child to acclimatize to have a device fitted over the ear. The speech and the language abilities are very important because if children have often said speech sounds, that means that their brain is receiving sound adequately. We have additional handicaps which worsen the condition of the children, especially if it is associated with affection of their cognitive abilities. We have other social and educational factors related to the family, such as the realistic expectation, the structure and support of the family to their children, and the family socioeconomic status. We have also factors related to the environment, such as the type of the environment, the mode of communication in this environment, either oral versus audio, visual oral. We also include factors like the post-implantation rehabilitation program and their designs. The second groups of preoperative factors, we included the selected devices, such as the speech processing strategies, where the many strategies achieve discrimination scores that is exceed 80% in comparison to only 40% in the older strategies. We have also the factors related to the implant, such as the insertion depths, which is dependent on the cochlear anatomy, surgical approach, and the type of the electrode array. And as a general rule, the deeper insertion depths have been associated with better hearing outcome. Other factors related to the inherent properties of the electrode array, such as their types, whether straight or contoured, stiff or flexible, long or short. Of course, selection of the electrode array is related to the surgeon, but in general, graded stiffness and the soft tip electrodes are less likely to cause damage than uniformly stiff electrodes. The device reliability. This means that reliability of a certain system that describes its ability to perform its required function under stated conditions within specified performance limits for a specified period of time. The long-term reliability of the cochlear implant are dependent on the number of the active electrodes inside the electrode array, where if they exceed 85% of the electrode, it will give a good results because they indicate sufficient stimulation of the neural population. Reliability also is related to the device failure, which include cases with non-use of the device. So the clinical number exceeds what is being reported by the manufacturer for this cause. Reliability also increase the reliability in the design of cochlear implant. This means that their housing and antenna are capable of resisting severe stress because they are made of titanium. It also includes a good insulation between the adjacent electrodes and less susceptibility to interference to external electromagnetic fields. They also include reliability and safety during the use in the medical treatment, such as MRI and ultrasound. The material of the CI must be biocompatible with human body to avoid reaction from surrounding bone and tissue. And they should be housing, which must be hermetically sealed from the body fluids. And in the operating theater, implant must be delivered in a sterilized container. The operative factors include group of factors. First, the surgical technique. We have two techniques, cochleostomy versus round window approach. Cochleostomy is very familiar to nearly all the CI surgeons. Some studies showed that round window approach is less significantly to be affected or to be less traumatic than the cochleostomy. However, the cochleostomy itself, it was found that the anterior inferior side is more associated with better residual hearing preservation. However, this point showed that there is still mixed results about each approach and its relation to preservation of hearing. The concept of soft surgery is relatively ancient since its discovery by Professor Leonard in 1993, and since that time it had been modified several times, with the main aim is preservation of the residual hearing. The basic principle of soft surgery include avoidance of blood entry into the scala tympani, avoiding bone dust entering the cochlea, application of steroid at the cochleostomy site, application of hyaluronic acid, avoidance of perilymphatic leakage and suctioning, minimal drilling to avoid noise-induced trauma and vibration-induced trauma, slow speed of insertion to reduce intracochlear pressure. It also includes mild hypothermia, which reduce immediate and delayed hearing loss, and also include a compromise in the insertion depths to achieve good high-frequency stimulation, and in the same time avoiding the interference with functioning of the cochlear structure. There is also use of some materials like antioxidant and neurotrophins to protect the cochlea against noise-induced and toxin-induced hearing loss. And more recently, there is also the addition of electrophysiological monitoring of EKG during the electrode insertion, which could guide the surgeon during the insertion of the electrode to preserve the cochlear structure. The surgical trauma. Surgical techniques may induce mechanical trauma to the cochlea or blood entry to the scala tympani. Surgical event cause adverse intracochlear reactions such as fibrosis or induce hair cell apoptosis or alteration of the endocochlear potential. Additionally, an autoimmune-like response may be evoked simply from the implant itself or to damage within the cochlea. The last factor is related to the operative complication. Generally, a CI technique is relatively safe with low rate of complications, which range between 6% to 36% in different studies. These complications include either intraoperative CI complication, including damage to the surrounding structure or difficulty during the insertion or CSF leak. There is also postoperative complication divided into two categories according to their severity and timing, either major or minor complication. Although these complications are neither permanent nor life-threatening, but they affect the outcome of cochlear implant because in many cases, they cause delay in the activation of the device and its interrupted use, leading to direct negative impact on early receptive language acquisition. So in summary, the success of CI depends on proper selection of the CI candidate, proper selection of surgical approach, the implant and management of complication, consistent device use, attendance at regular programming appointment and device maintenance, placement in suitable educational setting, available support and quality intervention service, and realistic expectation for both the children and their family, and finally, and not lastly, a strong family network and support. And thank you.
Thank you very much, Professor Takwa. Now we can have Professor Ossama for his talk.
مساء الخير. تقريبا دكتورة تقوى قالت بالظبط اللي أنا كنت عايز أقوله بدون أي تخطيط أو تخطيط ما بيننا يعني. Variability of cochlear implantation outcome results, and I will focus on 3 suggested variables. طبعا دكتورة تقوى اتكلمت على number of variables اللي ممكن تبقى affecting ال CI outcome. لما هنا in this presentation the importance of 3 suggested factors هتكلم عليهم. The first is spiral ganglion neuronal survival. The second is duration of having ample residual hearing prior to CI, and the third is soft surgery or trauma-free surgical procedures. In each of these factors, 3 points were considered. Can we measure or quantify these factors? Can we predict their role in CI performance before surgery? And finally, can we remediate these factors? As we all know, the spiral ganglion, we have type 1 neurons and type 2 neurons. Type 1 constitute the majority of the about 90% and only 10% for type 2. Type 1 innervates the inner hair cells, type 2 innervates the outer hair cells. The mechanisms of spiral ganglion neuron degeneration are many, and it's dependent on the cause. We have noise-induced hearing loss, we have ototoxicity, we have infections like cytomegalovirus is associated with the spiral ganglion neuronal damage, genetics, About 150 genes were identified to cause hearing loss. Most dangerous to spiral ganglion neurons are otoferlin gene, coding for otoferlin protein necessary for inner hair synapse functioning. Luckily, most genetic non-syndromal hearing loss is due to connexin 26 deficiency, which leads to hair cell loss but does not cause spiral ganglion neuronal damage. Also, we have aging, and aging is a very major factor in induction of spiral neuronal damage. Can we measure poor neuronal survival preoperatively? The answer is yes, but invasively, whether intraoperatively by EEBR and ECOG through promontorial stimulation, or of course post-operatively by studying the slope of the ECAP. If the slope of the ECAP is steep, then we consider this is a clue for good neuronal survival. If the slope of the ECAP, which is the input-output function of the ECAP, is less steep, then that's a clue for poor neuronal survival. Regarding spiral ganglion neuronal regeneration, currently there is no recommendation by any given drug or FDA-approved drug for spiral ganglion neuronal regeneration. The second factor is the duration of having ample residual hearing and linguistic abilities prior to CI. And the best example here is the cases of large vestibular aqueduct. In large vestibular aqueduct cases, hearing loss may start with mild sensorineural hearing loss, with progressive course ending up with CI candidacy. Frequently, children with large vestibular aqueduct develop normal speech and language comparable to their normal peers. And in this study, in 2018, we looked for the vowel perception test, and we found that cases with large vestibular aqueduct had the best scores compared to patients with large vestibular aqueduct and another anomaly, or patients with no anomaly in the inner ear. Again, the speech discrimination was much better in patients with large vestibular aqueduct alone compared to patients with large vestibular aqueduct plus another anomaly, or patients with no anomaly at all. The residual hearing that allows the development of some linguistic abilities was found to be a good asset for adequate performance after CI, as postlinguals show better CI outcome than prelinguals. Also, perilinguals show better outcome than prelinguals. The question, can we objectively assess the role of residual hearing prior to CI on speech outcome after CI? Yes. P1 of cortical potentials provide a good correlate to the central auditory maturation for both pre and post-implant children. It was found that there was significant negative correlation between the hearing age and the P1 latency. Children with progressive hearing loss show normal P1 development. The last variable that I will consider is soft surgery, and I will go over very quickly since it's about almost covered by Dr. Takwa. Regarding soft surgery, is very important the preservation of some crucial inner ear structures such as the spiral ligament, the modulus, the osseous spiral lamina containing the hair cell dendrites were found to be essential. Can we objectively assess soft surgery? Yes, by comparing unaided thresholds pre and post CI. Post-implantation pure tone threshold shifts were used as a surrogate measure for the extent of intracochlear injury and correlated with post-operative speech perception scores. Fundamentals of soft surgery, as Dr. Takwa said, of course, we have to avoid the introduction of bone dust inside the cochlea, which will induce ossification and subsequent death of the neurons. Careful drilling, because drilling induces a very high intensity sound, which could be injurious to the inner ear structures. The use of hyaluronic acid to lubricate electrode insertion was recommended. The use of the cochlear approach, and it was found that the round window is the natural and most anatomical approach to the inner ear compared to cochleostomy. The use of corticosteroids is very important because the introduction of the electrode array is considered a trauma, and in order to avoid the inflammatory reaction, we have to give the patient dexamethasone prior to surgery. The use of neurotrophins also was recommended in the literature. And to conclude that spiral ganglion survival, preoperative auditory and linguistic abilities, and soft surgery are 3 proved factors to have great impact on speech outcome post-CI. Efforts should be done to assess their impacts before surgery and to remediate them if possible after surgery. And thank you. دي فيلا في اسكندرية في وش الكلية بتاعتنا على طول، مبنية على طراز سويسري قديم، كانت بتاعت جوزيف جورا، كان تاجر قطن في اسكندرية زمان.
Thank you, Professor Ossama, very much for your nice talk. Thank you all my dear colleagues and professors. Now we are going to probably talk about the interaction of all these predictors that we have discussed, some of them. Actually, we developed what's called a scoring system for cochlear implant candidate selection using artificial intelligence. I'm going to present this work, but this work has been done with the help of my dear colleagues and professors, Professor Dr. Afaf Omara, Professor Dr. Mona Higazi from Ain Shams University, Professor Ines Kolkhila and Afaf Omara from Tanta University, Dr. Shaima Siraj from Tanta University, also from Phoniatric Department, Dr. Ahmed Fathallah, lecturer of Computer Science from Suez Canal University, and my student, Dr. Omnia Ismail. By that time, she was an assistant lecturer. Now she's a lecturer from Suez Canal University, Audiovestibular Medicine. The question that came to us to do this research was, how do we judge such a patient? If we have a patient with severe hearing loss of heredofamilial etiology who is 2 years old, never used a hearing aid but has a high IQ but with low social support, what should we judge? How should we judge such a cocktail? How should we judge the interplay of all these factors, which is some in favor, some moderate, and some less favorable? Another patient who has profound hearing loss of post-febrile etiology, but he is 3 years, but used hearing aid regularly, but he has a below average IQ with a high social support. Would such a patient be a better patient or a less better patient than the above one? So this is the real life situations. We all know the influence of each preoperative factor, but the question which is still open, how do these variables interact in real life in patients to let us have a judgment of these patients preoperatively? The judgment usually is subjective. Till now, all the cochlear implant teams and committees usually read the files of the patients with all these data and then judge such patients subjectively with their experience. But there is nothing objective till now. Till we try to improve the important questions, as I just mentioned, remains how good is this candidate, who achieved after doing so, how can we judge that he achieved a successful for him cochlear implant procedure, which cochlear implant program is doing better than the other, and how each program can measure its improvement. And we discussed the issue of added value. So we found ourselves in need of what's known a composite score. By definition, a composite score are calculated from data in multiple variables in order to form a reliable and valid measures of latent theoretical constructs. When there is an overflow of data, you need a composite score which expresses the interplay of such variables. For example, what a very common popular composite score that we know is like the Gabr score, for example, which is a score for the viability of neonates. The absence of such a scoring system prohibits us from measuring the added value for each patient, and accordingly we cannot improve the outcome, as we cannot improve what we cannot measure. The aim of our work in such research was to develop a method, predictive scoring system for CI candidate selection, and after we developed such a scoring system, we should validate this score or model, and then develop a tool that help assess the added value for each CI patient, knowing his preoperative condition and knowing his postoperative condition, and in relation to each other, we can see, did we do our job or not? The subjects were a retrospective cohort study. Was a multicentric study that was carried out with the help of 3 post-CI rehabilitation centers, having full data of 350 records for children who had cochlear implantation during the period from 2012 to 2020, and data were collected from June 2018 till June 2021, and was broken due to the COVID-19 outbreak by that time. We included children of both sexes below 18 years old with prelingual hearing loss, with unilateral CI, with children with should have received rehabilitation equal to or more than 1 year, and we excluded patients who had reimplantation or children diagnosed with auditory neuropathy spectrum disorder, patients who had postoperative complications or uncompleted records were also excluded. We also excluded all patients with malformations. We took a classical patients to develop such a model. We invented 3 measures called the language age deficit, the phonological deficit, and the social deficit, in which we calculated as the difference between the chronological or phonological or social deficit and the corresponding language age or phonological age or social age at the same time of evaluation. And then we categorized the post-operative or the post-CI categories from into 6 categories: slight, mild, mild to moderate, moderate, moderate to severe, and severe. We tried to have such a composite score using conventional statistics, but it was a big failure. There was nothing in the conventional statistics that can answer such a question. With all these variables, we didn't find anything, so we went to artificial intelligence and machine learning. We fed the artificial intelligence machine learning softwares with the preoperative conditions and then with the postoperative conditions that we have, and then we tried to let the machine give us the after the machine learned these preoperative conditions would yield such a postoperative conditions. So then, when I tell you a new conditions, can you predict what will happen? And then we validated this. So the results were, first of all, the results of the machine learning, it gave us the differential weight of different preoperative conditions. And we found that the most important 2 factors that determined that had a major contribution in the outcome were the average duration of auditory deprivation, in which I think Dr. Ossama mentioned this factor, which is the period during which the child or the patient was deprivated from his audition before he put the hearing aid or whatsoever, and the family support. So these were, and then gradually all other factors had a different differential weight in deciding the outcome. And of course, this depended only on the limited number that we saw. And of course, there is a major concept in artificial intelligence and machine learning, as that the more information you give, the more accuracy the results will be. Regarding the language age deficit, we could reach a predictive score with a 56% accuracy, what's known the Adel SMO model. For the phonological deficit, we could reach an 88% accuracy in predicting the outcome, and the social deficit was the less, which was 40% only accuracy in predicting the outcome of its social abilities of the post-operative CI. And we contributed this to that the social maturity is not only dependent on audition, but there are other factors probably not put in such a model. We also tested what's known the regression predictive score, which is the ability to measure the gap between the actual performance and how can this model be accurate in predicting to which extent the patient will be delayed or not. And it was also more accurate with using the artificial intelligence than using this conventional statistics. We concluded that this work demonstrated new post-CI performance measures, language age deficit, phonological deficit, and the social deficit, and we proved that the traditional statistics could not satisfy our answers, and we, with the help of AI, the performance was better. And although the machine learning classification model's accuracy for language age deficit and social deficit was less than 70%, indicating a high error rate and less reliable prediction, this would be improved by obtaining more data. And so we consider this as a prototype, as a primitive model that needs more and more update. And now by that time I wrote a software is being under preparation. I think we prepared it already, and now it's done, and it's now in multiple other regional centers collecting the data for the next phase of, we recommend constructing a database system, and it's already been done, and we are collecting the data now from many centers in the regions. And of course, the future is open for collecting more data regarding some special data about the auditory neuropathy spectrum disorders, challenging cases like cochlear malformations and other things like that. And formulation, a predictive score for the post-lingual hearing loss also is another horizon. And thank you for listening.